and Dr. Brent Taylor. Are you all at the table? Would you please rise so we can swear you in, please? You solemnly swear to tell the whole truth and nothing but the truth, so help you God? Have a seat. Dr. Wakefield, would you like to start this panel?
Yes, thank you, Mr. Chairman, members of the committee. It's a great privilege to be here. The purpose of my testimony is to report the results of the clinical and scientific investigation of a series of children with autism. Now, nothing in this testimony should be construed as anti-vaccine. Rather, I advocate the safest vaccination strategies for the protection of children and the control of communicable disease. I also am here on my behalf representing the children who have come to me for investigation. I'd like you to look at the screen, if you would, please, and I'll take you through the presentation. Next slide, please. As a little bit of background, this represents 12 years of intensive clinical and scientific research, collaborative research, into the causes and mechanisms of bowel inflammation. I'm a gastroenterologist. The principal authors of this work have contributed to over 1,500 peer-reviewed and published papers, scientific papers, and abstracts. And again, these represent my views. Next slide, please. I want to report the results today from the first 60 children that we have investigated. We have now investigated over 150 children, and the results that I'm going to describe are pertinent to all those children bar about 4. The range of psychiatric assessments, the great majority had autism, but there was a spectrum of neuropsychiatric problem, including Asperger's syndrome and attention deficit disorder. And by far and away, the most important investigation has been direct visualization of the bowel and taking biopsies by the procedure of ileocolonoscopy. This is a flexible instrument introduced into the bottom end to take a biopsy. Next slide, please. What you've heard this morning is a classical description of 2 different types of autism from the parents. You have heard about the children that we have seen, those who have gone off after a period of normal development in the face, many of them, of multiple vaccine exposures with severe gastrointestinal symptoms. The other type, described very articulately, was of an insidious failure to acquire skills. That is an extremely important point, and the essence of what I'm going to present today is based upon conventional clinical medicine. It is listening to the patient. Here is a child who was entirely normal for the first year of life and went off a week after receiving his MMR vaccine. He is exactly as the 4 were described earlier. Next slide, please. The classical features in these children are of pain. There is a radiograph here of the abdomen, and there is fecal impaction. When these children came to us, the feature was of diarrhea, but in fact this turned out to be what we call spurious or overflow diarrhea. There was soiling, loss of continence, fastidious eating habits, reflux and nighttime wakening. They get heartburn, and they wake up very distressed. And these symptoms are the same wherever you go. If I listen to parents from Canada, from the States, from Europe, from Australia, the story is the same. Next slide, please. The associated features that we have in these children are of atopy, asthma, eczema, and hay fever. There is a refractory upper respiratory tract infections. They do not deal with common childhood infections, colds, well. And there is a very high level of autoimmune disease in the family, thyroid disease, diabetes, for example. Next slide, please. This is the insider's view of the small intestine. The panel on the top left is of what it should look like in a child. The bottom left is of lymphoid nodular hyperplasia. These are swelling of the lymph glands in the bowel. These are rather like tonsils, and when they swell, they cause pain and symptoms. And Mr. Waxman asked for reproducibility. He's absolutely right, and up on the top right-hand panel, you see a child who was scoped in the United States with exactly the same symptoms. So this is reproducible in 2 different continents. We've compared it with controls, and the graph on the bottom right shows that even in children who come to us with gastrointestinal symptoms who are scoped, the finding of lymphoid nodular hyperplasia is relatively uncommon. The bar on the left, 85% of them show no evidence of it, but virtually all of our autistic children show evidence of lymphoid hyperplasia, either mild, moderate, or severe. Next slide, please. There are histological changes down the microscope which show there is a definite disease. The top left-hand panel is normal. The bottom right-hand panel, for example, shows what is called a crypt abscess, that is pus in the bowel wall, and this is a feature that we see in children and adults with ulcerative colitis. There is a clear, demonstrable, albeit subtle pathology. Next slide, please. A further paper that's due to be published soon has taken this to one further level and asked, is this disease distinct from classical inflammatory bowel disease, Crohn's and colitis, or is it something new? And the data, at least so far, suggest that it is something new. Next slide, please. We have described this feature in the gut, lymphoid hyperplasia and colitis, in children with autism. From this same city, from Georgetown University, Professor Joe Belanti has described it in children with attention deficit disorder. Coming back to the question, is this a spectrum of disorders which have at their heart some gastrointestinal abnormality? Next slide, please. Lymphoid nodular hyperplasia classically occurs in the presence of immunodeficiency. We do see it during acute infection, but it's classically associated with immunodeficiency. Are our children immunodeficient? As a group, the answer is yes, they are. And this graph just shows you a particular count of a certain type of immune cell in the blood, and these are the green line is the upper limit for normal, the red line is the lower limit for normal. Each blue dot represents a child, and you can see that the great majority sit at or below the lower limit of normal. Not only are they numerically deficient, their immune system does not respond appropriately to common recall antigens when compared with normal age-matched children. In other words, if you give them a skin prick test for pertussis or diphtheria, they mount no response. Next slide, please. So the key features of the syndrome are developmental regression, ileocolonic lymphoid hyperplasia, swelling of these tonsil tissues, enterocolitis, that means inflammation of the small and large intestine, and an immunodeficiency. Next slide, please. So it's a real syndrome. There is a remarkably consistent pattern of bowel inflammation, and it provides us with vital clues. Now, what are those clues? Next slide, please. Well, the story as told to us, which we have an obligation to report, is that the majority of children regressed following a period of normal development in the face of MMR vaccination. That does not mean it is the cause of the disease. We also had 2 children who regressed after classical measles infection, one after the monovalent measles vaccine, and one after a rare vasculitic rash. 36% of parents could contemporaneously identify no particular environmental hit. Next slide, please. Has measles, have common childhood infections been linked to autism before? Is there a reason to go into this and look at it? The answer is yes, there is. And this is a paper that came from the Harvard School of Public Health, and it showed that atypical patterns of exposure to common childhood infections, measles, mumps, chickenpox, rubella, were a risk for autism in the child. By atypical, I mean maternal exposure when pregnant or neonatal exposure. What was intriguing about this, and which we may come to later, is that if you were a pregnant mother who was exposed to more than one of these common infections at the same time, or indeed an infant child, then your risk of autism was both greater and the severity of the autism was greater. Question, was there a compound effect of more than one infection? It's also been shown that children born in and around epidemics of measles and rubella have higher rates of this disease. Next slide, please. What about vaccines? This is a paper from the Vaccine Damage Compensation Board in the United States. Acute encephalopathy followed by permanent brain injury or death associated with further attenuated measles vaccine. What was intriguing in this cohort of children who fulfilled rather strict criteria is that 43 of 48 underwent developmental regression as part of their syndrome. So we have this other pattern of exposure to measles as the further attenuated vaccine, children undergoing developmental regression. Next slide, please. So to summarize, that unusual patterns of exposure to common childhood infections are associated with autism and developmental regression. Next slide, please. Now here is the clue. This is the important image, and here you see the insider's view again, this swollen tonsillar tissue, because this, if you are looking for an infection, is where you should be looking. Next slide, please. When you look down the microscope, this is what that swollen tonsil tissue looks like, and you are looking in the center of that for the infection. This is a response to a foreign agent, a foreign antigen, usually an infection. And so if you are looking for the cause of that, that is where you are looking. Next slide, please. This is a very high power micrograph of a single cell called a follicular dendritic cell. And this is crucial because if you are looking for the source of that infection, not only are you looking in that lymphoid follicle, not only in the center of the lymphoid follicle, but in this specific cell. Next slide, please. When we look in that specific cell, using an antibody which picks up measles protein and only measles protein, we find it in that cell. We do not find it in other cells throughout the tissue, we find it in that cell. Next slide, please. You look for other viruses. You ask the question, is this just a non-specific response? Do we find other viruses in there? So you look for adenovirus, herpes simplex 1 and 2, rubella, mumps, HIV, and other crucial controls that Mr. Waxman referred to earlier, and you do not find them. They are not there. So at least within the context of this study, this appears to be specific for measles virus. Next slide. Next question, is there an antibody? Is there an immune response to the virus in these children? The mere presence does not make it the cause. Is there an immune response? We take the children, the autistic children, and we compare them with age-matched controls, and we look at measles antibody titers. We also look at controls of mumps, rubella, and cytomegalovirus, other common childhood infections. The only one for which there is a statistically significant difference between the cases and the controls is for the measles virus. Next slide, please. We had failed completely to identify this virus by molecular amplification technology. In my laboratory, we had a reaction that was sensitive to about 10,000 copies. Anything less, we couldn't find it. The Japanese had succeeded, and so we sent 9 blood samples from our children to the Japanese laboratory. We also sent 21 other patients. We mixed them up. We did not tell them what they were getting. They just had a label, a control label, and they identified measles virus in 3 of those 9 children in the peripheral blood. And that is an intriguing finding. This is consistent with, but not definitely vaccine strain. One cannot say that. This is consistent with, but there it is. And this was a blinded controlled study. Next slide, please. Very briefly to finish up, what is the link between the gut and the brain? Because this is one of the most difficult things for people to understand. How can the gut influence the brain? I come from a liver unit where we see patients with chronic liver failure, acute liver failure all the time. And one of the classical manifestations of that, next slide please, is hepatic encephalopathy. And this is where the gut, the liver is damaged, is diseased, and fails to degrade the chemical constituents of the bowel that come through. It fails to mop them up and clear them out. They impact upon the brain. This is largely reversible. If you're hit with these for long enough, it becomes irreversible. And the question is, therefore, at least we have biologically a plausible hypothesis, a testable hypothesis, that elements from the gut, undegraded chemicals from the gut, including the opioids that were referred to by Shelley Reynolds, may be getting through, may not be metabolized, may be impacting upon the rapidly developing brain during the first few years of life and producing residual cognitive deficit, which we recognize as autism. Next slide, please. And so finally, in summary, we have an environmental insult in perhaps a genetically susceptible child. The problem is that if you go to Sweden now, autism affects over 1.2% of the pediatric population. So if that is a genetic background, it is clearly widely distributed within the population, that we believe that in many children, clearly this subset of autistics, it leads to gut infection and damage. That leads to an ingress, an impaired metabolism, degradation of these chemicals from the gut that then get through an impact upon the brain. And the dysregulated immune system, which measles classically can produce, also encourages immune diseases, atopic diseases, and immunodysregulation. Thank you, Mr.
Thank you, Professor O'Leary.